Thank you so much. I think you may have heard this talk multiple times with some personal experience sharing. So we're going to talk about anti-angiogenics in advanced NSCLC treatment, and in that the focus will be on Cyramza. So we have multiple targets that are being utilized, targeted therapy, anti-angiogenics that are being utilized in the management of advanced non-small cell lung cancer, in which we are all familiar with the ECOG study where we used bevacizumab, we have nintedanib, and we have ramucirumab. And in the next 20 minutes, I'm not able to advance. Okay. Yeah, in the next 20 minutes, I'm going to be focusing on the role of ramucirumab in driver mutation positive here, EGFR mutated non-small cell lung cancer. So when we look at the first line application of EGFR mutated non-small cell lung cancer and the role of ramucirumab, it is the Relay trial that was presented in 2020. And I have also been using ramucirumab as a part of the Revel trial way back in 2012, and then the study got published in 2014. And this was in second line NSCLC setting for squamous and non-squamous, where ramucirumab was utilized with docetaxel. So I was a part of this study. And then later on, now we are here with Relay trial, and we have the application of ramucirumab in EGFR mutated lung cancer. So what is the optimal management for EGFR mutated NSCLC, and what is the timeline of drug development? We are all privy to this. So it all started with gefitinib, and then erlotinib, and then many stories of gefitinib in this country, and then the gefitinib in the West, and erlotinib in the West, and then afatinib, dacomitinib, osimertinib, and ramucirumab. Post that, amivantamab and mobocertinib, and all these drugs addressing EGFR positive disease. The story begins with the NEJ002 WJ-TOG study, and that was gefitinib versus chemotherapy, when we first realized TKIs were better for advanced EGFR positive NSCLC. And then comes optimal and URTAC for erlotinib versus chemotherapy. And I always say this, it's about drugs versus drugs. It's dueling out in the arena for drugs to supersede the others and show up as the winner. And that's how the drug development happens in oncology. And then it was Lux Lung 3 and Lux Lung 6 with afatinib shining as the star, and then Archer with dacomitinib, and Flora with osimertinib. And then comes in the Tata data with Dr. Narona's trial, where gefitinib plus chemotherapy versus gefitinib alone was the winner. And multiple studies then, couple of studies then coming out of Japan with NEJ009, NEJ026, where gefitinib plus chemotherapy, erlotinib plus bevacizumab, and the data is out here right in front of you. Now a look at the median PFS in all these studies, and bottom line here with Relay. Erlotinib plus ramucirumab versus erlotinib, and a median PFS of 19.4 versus 12.4, and an OS that hasn't been arrived yet. Going back to the previous slide, look at the median PFS and median OS in various other studies. Historically speaking, you have a PFS range from 9.6, 9.7 to 18.9 in Flora, and you have 19.4 in Relay. You have chemo plus gefitinib, and you have a median PFS in NEJ009 of 20.09 months. But then the conversation comes in whether every EGFR is the same. And to that, one knows the answer. It isn't. However, all these trials that I just enlisted, lumped all the EGFRs together, exon 19, exon 21, they were all lumped together, and you have the data combined of both these prominent alterations, EGFR alterations together. However, we all know that now the field has evolved to understand that exon 19 and exon 21 L858R are not the same, and so aren't the uncommon EGFR mutations and the exon 10-20 insertions. The time has evolved, and now we treat each one of these differently, and that's how this discussion with Relay is being presented. How is L858R different from exon 19? A few slides on that. And when you look at this slide, you have it clear. The green box is with, is my cursor visible? Yes, the green box is with L858R, and this is the tumor mutation burden. And you see that the TMB for L858R is higher. And again, in this image, you again see that the TMB for L858R is higher than exon 19 deletion tumors. When we look at concomitant mutations and the outcome, again, the occurrence of concomitant mutations in L858R is 69% versus 41% in exon 19. And with the PFS and OS also, you see the difference. The PFS is higher for non-co-mutated, where there was no concomitant mutation detected, versus where the concomitant mutation was detected. So PFS 18.7 versus 6.2, and OS not reached versus 22.7. And so it's from this particular study done in China, the fact becomes apparent that L858Rs had more concomitant mutations, and hence compromised PFS and compromised OS as a result of that. And then you have multiple trials enlisted here in the bar graph diagrams, where you see the PFS varies when we go from exon 19 deletion to exon 21 mutation with different drugs. With osimertinib, you have a PFS of 21 months for exon 19 versus 14.4 months for exon 21. Similarly, in the LUX-Lung-3 study, with afatinib, you have exon 19 with a PFS of 13.8 versus 10.8. Yurtac, 11 months versus 8.4. And Archer with dacometinib, 16.5 versus 12.3. So this slide makes it very clear that the behavior with the same drugs of exon 21 L858R is consistently different than exon 19, the behavior of exon 19 with different drugs. So you have higher PFS, exon 19 is a better behaved alteration than exon 21. There comes Relay, where you have stage 4 NSCLC, and you have EGFR mutation positive exon 19 deleted, as well as exon 21 mutated tumors. PS of 0.1. Key exclusion criteria was previous EGFR directed therapy, TKI or chemotherapy, brain metastasis, and EGFR T790M mutation. This is one of the limitations of the study as well, because no brain metastasis patients were included. It was a phase 3 trial, and there was a 1:1 randomization, ramucirumab plus erlotinib versus placebo plus erlotinib, and ramucirumab was given at 10 milligram per kilogram every 2 weeks. The treatment was done until progression or unacceptable toxicity or non-compliance, and the primary endpoint was progression-free survival. The secondary endpoints were safety, overall survival, and duration of response, and the stratification was done between exon 19, exon 21, sex, region, and EGFR testing method with Therastrine or Cobas or others. And so if you see here in the baseline characteristics, Asians were very well represented. You have 172 patients and 172 patients in either arms, and significant percentage. When you look at the EGFR mutation type, the exon 21 L858R mutation was also well represented in this study. Mostly the tests were done with TheraScreen and COBAS. You have the 1-year progression-free survival rates enlisted here, and the median progression-free survival was 19.4 months versus 12.4 months, and 1-year PFS rate was 71.9% versus 50.7%, clearly with an advantage to the experimental arm with ramucirumab and erlotinib. Now dissected mutation-wise or alteration-wise, you have deletion 19 and you have the L858R. And you see the advantage for the experimental arm with combination ramucirumab and erlotinib versus erlotinib alone. And when you look at the L858R and the PFS, you had seen in the previous slide where between the exon 19 PFS and the exon 21 PFS, there was a remarkable difference, significant difference. Here, you don't see the difference. That difference is made up. So if you recall, with osimertinib, the PFS for exon 19 was 21.4 months, and for exon 21 L858R was 14.4 months. Vis-a-vis what we see here, the PFS with ramucirumab plus erlotinib for exon 19 is 19.6 months, and L858R is 19.4 months. So the study and the combination actually equates the behavior of exon 19 and exon 21. Then coming to overall response rate and duration of response, you have the duration of response curve here, 18 months for the combination versus 11 months for erlotinib plus placebo. And the median duration of response, 18 months versus 11, we just discussed. Overall response rates were similar in both arms. But mind you, once the patient went into response, the response was more sustained for the experimental arm than for the placebo arm. When you dissect it again by EGFR activating mutation subgroups, the duration of response consisted to be higher for EGFR exon 19 and EGFR exon 21 L858R consistently across the two mutations with the experimental arm. Exon 19 deletion was slightly a better behaved alteration with a 2 months difference in duration of response, 18.2 versus 16.2. But when you looked at 21 L858R with experimental versus placebo arm, the experimental arm continued to perform better. PFS2, we are all familiar with the PFS2 phenomenon, and again for the PFS2 with the experimental arm you had advantage with addition of ramucirumab to erlotinib, and again sustained when you dissected by the mutation between exon 19 deletion and 21, sustained survival advantage for PFS2 advantage for even 21 L858R patients treated with the combination arm, the experimental combination. Time to chemotherapy by baseline EGFR activating mutation subgroup, and again the time to chemotherapy was delayed by giving ramucirumab in addition to erlotinib, and it was sustained in both exon 19 as well as exon 21 L858R. So consistently I'm giving one message after the other that the job that ramucirumab did was it made exon 21 look like exon 19. By adding ramucirumab, that's what you did exactly. Now coming to the treatment emergent adverse events, and here by personal experience, I would say the drug is very well behaved. I've hardly ever had any major dramatic events However, I would like to mention what is out here, and that is mainly hypertension. If you look at the grade 3 hypertension, so just mainly the grade 3 column, if you look at the grade 3 column, the higher ones are hypertension, and that's different, that's significantly higher in the experimental arm, and acneiform dermatitis. Special interest adverse events, and again hypertension stands out. Proteinuria is something to take note of. However, the grade 3 proteinuria rates were not that high. And if you go down here, the liver enzyme elevation is also something to note, although it is mainly the hypertension rates that are high enough to take note of. I would just like to mention about bleeding. So there are 3 different kinds of bleedings listed here: epistaxis, GI hemorrhage, pulmonary hemorrhage. And if you look at the grade 3 column, it's almost equal or mirror image of the experimental arm is a mirror image of the placebo plus erlotinib arm. So that's something to take note of. You have minor bleedings that could be seen, epistaxis being one of the commonest, but any major bleeding event was extremely rare in the study. And the serious treatment-related adverse events were actually quite comparable in the experimental versus the placebo arm. EGFR T790M mutation rates were also lower with ramucirumab plus erlotinib, as you can see in this in this bar graph. Numbers were almost comparable, so there was no increment in the EGFR T790M rates. So what was the past standard of care? We know that the past standard of care was first generation, second generation TKI, and then the patient evolved to get T790M mutation, and that's how osimertinib was approved. And then comes in the current standard of care with osimertinib being the frontline drug, and if there is a progression, you figure out the reason for progression, and then you cater to whatever has happened to the patient by giving chemotherapy or something else. An alternative standard of care is proposed here in this slide, where for specifically EGFR exon 21 L858R, you have erlotinib plus ramucirumab, and if upon progression the patient is found to have T790M rates, you have osimertinib to go to. So actually I misspoke in the previous slide. The idea was to tell you that addition of ramucirumab does not decrease the rates of T790M occurrence, and that opportunity you still have to give the patient in the next line if the patient turns out to be T790M after the first generation utilization, that you can still give osimertinib for those patients. So that could be an alternative standard of care with osimertinib in frontline setting for specifically for EGFR exon 21 L858R mutated patients. I finish with a case wherein this is a 39-year-old with no significant comorbidities and slowly increasing shortness of breath, fever, and compromised performance status. And you can see the lung is studded with disease. And this on examination was negative for TB and positive for EGFR exon 21 mutation, and tested both in tissue and liquid, followed with liquid, started on erlotinib and ramucirumab, tolerated very well. And here's the X-ray 4 weeks later, already seeing a response. Follow-up 3 months later, response is sustained, and 2 years later, further sustained response. So I think this slide is not a surprise. We all know that the responses start within 2 weeks of starting the EGFR TKIs. This slide is also not a surprise. The 3 months could still be sustained. But on erlotinib, this slide is a surprise because the response continues to be sustained, and in this case, because the ramucirumab was added, especially because the alteration here is EGFR exon 21 L858R. I hope I've made my case. I have a patient right now who's under treatment going on to his 3rd year with adenosquamous, initially diagnosed as squamous, treated with chemotherapy, pembrolizumab. Upon progression, had been biopsied earlier, biopsied again, and that biopsy showed features of adeno and exon 21 L858R mutated. And this patient went on erlotinib and ramucirumab, continues to be in complete response, almost 3rd year, going to his 3rd year. So I think all of us have cases in our clinics where we have treated them differently. The one message I have always left with wherever I'm speaking is the exon 21s should not be taken lightly. Those are the bad behaving patients. Those are the patients who are EGFR mutated, who will behave differently, who will explode, who will metastasize, who will progress. That's where this kind of combination comes in handy. As you saw in the presentation, essentially what ramucirumab is doing is nullifying the aggressiveness of exon 21. Until we find a better drug, this should be the method of choice. Thank you. Please.
So, can you please help me understand why response to the combination is sustained for 3 years and you compare it with only erlotinib, which you referred that generally gives a response for few months. However, we have seen several patients which are EGFR mutated and they are very good responders. They are going far beyond 3 years, although the proportion is very low. So from this data, can you help me understand what proportion of patients are going beyond 3 years in the combined therapy response?
So if I look at the relay data, we discussed that the median PFS was 19.4 months, 19.6 months. So I would agree that the 3-year story is an outlier. When you talk about the bell curve, you're talking about the other end of the bell curve. And I think all of us will have EGFR exon 21, a rare case where even with osimertinib, the patient would be going on to the 3rd year. So 3rd year is not the point. The point is what difference I showed in that slide, where multiple different drugs, trial after trial, we have understood that exon 21 behaves differently. I had a young female who presented to me with exon 21 L858R. I remember at that time Relay had not come in, and I remember talking to her. I even remember her name. I remember talking to her and telling her, you have EGFR mutation positive lung cancer. You're going to live forever. I am telling you this. And her child goes to Oberoi school with my child, and she is no more. Okay, so I fought for her. I fought for her with everything, and that's where I'm coming from. That with her case, that one case, it just went in my mind that this is not a simple EGFR. You couldn't figure out what was wrong with her. I was giving everything and moving over, and still you couldn't contain the disease. So I feel that EGFR exon 21 L858R needs to be understood better. Until that happens, until that one wonder drug comes in, this is a combination that has to be thought of. And I've said it to the Lilly guys again and again. One would wait for the TKI that would cross the blood-brain barrier in combination with ramucirumab, so that you have everything covered. And someone wrote about it saying best of both the worlds. So that is what one is seeking. But at the same time, the realization that this is a different alteration than exon 19 is the message that I want to leave you with. Yeah, I'm sure you've all had these experiences in your clinics, but for me it has been very profound, and I've moved over. So thank you. Thank you.
So
Please.
the combination was with the erlotinib. So wasn't the osimertinib considered over here?
Yes, ma'am. So that's a trial that's ongoing. That's the study I was mentioning, and I've harassed them a good amount of time to say when is it coming, when is it coming, when is it coming, because that's the best combination. You want to give osimertinib with ramucirumab and be done with it. And outside of the PAP, do I have patients? Yes, I have patients. I am giving osimertinib plus ramucirumab, but that's outside of the PAP because you can't get the PAP for that. Yeah. All right. Thank you. Thanks for the opportunity.